So it's going to be a little bit unconventional because I'm actually sharing the lecture with actually a colleague and a friend, Dr. Jean-Paul Praud. We're going to talk about the physiology of non-invasive ventilation and non-invasive NAVA in particular. I'm going to start with a disclosure. I am a consultant to Mackay, and also I speak a lot at congresses that are organized by them. And as well, because I am a co-inventor of the technology and we have patents, I do receive royalties, so just keep that in mind as I'm speaking. Okay. I'm going to start off by, since this is the first talk on non-invasive ventilation, just starting off with the definition and the goals, or as Paolo said, that Tobin says, the objectives of non-invasive ventilation. So non-invasive ventilation is mechanical ventilation that's delivered with intermittent inflations. So this is NIPPV for the neonatal people. It's not CPAP. It's usually given with PEEP to the airways via a non-invasive interface, which means basically we don't use an endotracheal tube. The goal of non-invasive ventilation is to maintain, again, just like invasive mechanical ventilation, adequate oxygenation and adequate ventilation. We want to reduce the work of breathing, and we want to keep the lung open without over-distending. In order to avoid complications, non-invasive ventilation should be synchronized to the patient's breathing effort, and that's mainly what I'm going to be talking about is the synchrony aspect of delivering non-invasive positive pressure ventilation. So what are some of the factors that affect how well we are delivering non-invasive ventilation? So I'm going to go back a little bit to how spontaneous breathing originates. Paolo went through this quite a bit, but you have your breath that starts here in the central nervous system in the respiratory centers. Signal goes down through the phrenic nerves. The diaphragm becomes electrically activated. Then the diaphragm contracts the chest wall, and the lungs expand, and you have flow and pressure at the airway. And if you were to use this signal, which is your conventional pneumatic signal, to control a ventilator, to start its timing in terms of starting the breath and ending the breath, if there's a leak present, then this will affect how the ventilator interprets the control. So in the case of a leak, it might be detected as a patient effort when really it's just the fact that it's the leak. So you would have the ventilator cycling on and it's not a true neural effort. So we have our pneumatic controllers. There's also been some work done on the Graceby capsule in the neonatal world. It's a small little capsule you place on the abdomen, and it detects movement of the diaphragm. This has been used to as a trigger mechanism, but the inspiratory time still has to be dialed in, and still no one has really validated what the Graceby capsule performance is with respect to diaphragm activity. So this is what we've been talking about all day, using the electrical activity of the diaphragm to control the ventilator. And you can see here that this is what we call a pneumatically independent signal. Here, the fact that air is leaking affects these signals, but this is an electrical signal. It's pneumatically independent, and that makes it very ideal for controlling the ventilator. So that's one of the factors that affects the delivery of non-invasive ventilation and patient ventilator synchrony. The other thing is we have very inadequate monitoring with the conventional pneumatics. If you are measuring tidal volume at the airway and you have leaks, it's an unreliable signal. But now we have this neural signal that can tell us about whether or not we're being efficient in the way we deliver the assist. Of course, if you also have leaks up here, this will affect your pressure delivery. So even though we have a nice signal for controlling the ventilator, when to start the breath and when to end it, NAVA will still be affected by leaks at the interface because of the pressure delivery will be affected by that. I'm going to talk a little bit about the properties of interfaces. I'm not an expert on them, but I'll show you some of the work we've done with leaks, and I've looked at delivering non-invasive NAVA with different prong sizes, and I'll show you some of the work also with the helmet. And then at the very end, and I highlighted this in bold because Dr. Praud's an expert, there you are, in upper airway physiology, and we started to do a lot of work about the upper airways and how they're synchronized to the diaphragm and how this affects non-invasive ventilation. I put this slide up here just to remind myself, as Dr. Stein said, all babies in the neonatal unit who aren't yet feeding are being fed through a nasogastric feeding tube. So for non-invasive ventilation in the babies, it's not an issue. And in the adult world, there is an 8 French adult catheter that you can use. So if the patient is on non-invasive ventilation, you have a thinner catheter, that doesn't necessarily have to be used for feeding. This is the original work that we did in our lab and shows the very first work done on non-invasive NAVA. We did a study in rabbits, approximately 4 kilos in weight, and what we did was we did a lung injury on them. We instilled hydrochloric acid, and we have the EDI catheter measuring their diaphragm activity, and what we're doing is we cut an endotracheal tube and we just inserted the tube into one nostril, and the other nostril was free, the mouth was open, so you have a huge leak. And what we did was we tried to ventilate them first on pressure support with a pressure trigger. Here you have your diaphragm electrical activity. This is the ventilator pressure measured up here at the prong, and this is the esophageal pressure that we measured with an esophageal balloon. And this is not using the Servo-I and their new software. This is an old prototype on the 300 that we were controlling. And you can see here that despite that the animal was making repeated neural inspiratory efforts to trigger the ventilator, and you can also see here by the esophageal pressure swings that the ventilator could not detect any effort because of this huge leak. After a few minutes, the blood gases deteriorated. And then when we simply turned the switch, which was we actually had the capability with our setup to flip from pneumatic pressure support to NAVA, you can see immediately that we were able to get assist being delivered in synchrony and in proportion to the diaphragm electrical activity. And in doing so, we immediately unloaded the respiratory muscles as well, and we were able to restore the blood gases. So I know you're all tired, and this is one of the last lectures of the after lunch, but if you take home anything from my lecture today, take home this picture, okay? The pressure support, the NAVA. These are some more of the tracings that we obtained in that study, and it looks a bit scary at first, but just has some important points. So what we had was we had our rabbit who was orally intubated, and what we had was just plain and simple. This is after the lung injury. This is the diaphragm electrical activity signal, and this is the airway pressure that was being delivered. And in these rabbits, because you do the lung injury, they get a lot of tonic activity, and you have to give quite high PEEP to restore their phasic breathing. And you can see that here. What we did was we kept them on NAVA, but we removed the PEEP. So here the PEEP was 7. We went down to 0. You can see the pressure dropping. And you can see here immediately that when we removed the PEEP, that the lungs de-recruited, and through vaguely mediated reflexes back to the brain is saying, uh-oh, I'm de-recruiting, open me up, open me up. So the diaphragm stays active tonically in this situation when you have no PEEP to help. And then what we did was we pulled out the oral endotracheal tube, and thereby we liberated the upper airways, and Jean-Paul will talk a bit more about this, but you can see immediately that still with no PEEP, and we had taken off the NAVA by this time, we had very large diaphragm electrical activity, but there was no tonic activity. So something now is helping the animal to recruit the lung, probably the upper airways again. You can see here a very low NAVA level, very little assist. When we increase the NAVA level progressively, you can see here that we're actually able to give more assist, and you get deactivation of the diaphragm as you unload. And in fact, when we reach 4 times the NAVA level, the EDI values return to the pre-extubation values here. But you can see here that we actually needed 4 times as much NAVA level to accomplish this. So the point I wanted to make with this slide is really about the monitoring capability, that as you increase the assist level, you actually, for the first time, can actually see that you're actually unloading the patients. Just to go back here, just so you can see here the peak pressures that we were applying, around 40 or 50 centimeters of water to be able to account for this huge leak. And that might be of some concern to people who have read this paper, which showed an increased risk of gastrointestinal perforations in neonates. And you can see here that those infants who had a gastrointestinal perforation actually had 19 centimeters of water pressure support, and those that didn't also had very high pressures. But you can see here, and what they found was that this incidence was associated with the delivery of non-invasive ventilation compared to endotracheal intubation. In our rabbit studies, I've plotted here the mean level of assist delivered with increasing NAVA levels, and you can see here this would be about 30 or 40 centimeters of water in peak pressure. But when we measured the gastric pressure with a gastric balloon, you can see here that we did not see a increase in the gastric pressure. And probably this is because when the animal is breathing in and receiving the delivery of the assist, the glottis, the lungs, everything is ready to receive air and nothing goes into the stomach. Whereas if you were asynchronous with the ventilator, it could be that the ventilator would push air into the stomach. And we haven't seen this in the animals. I don't know, maybe Howard will talk about this later. This is what non-invasive NAVA looks like in a preterm baby, and I think Howard's going to show a lot more about that. But you can just see here that when the leak in this case was 97%, you can see here that despite that huge leak, we were still able to maintain the synchrony, both in terms of the timing of when the ventilator starts, when it cycles off, and also that smaller efforts give smaller breaths, larger efforts give larger breaths. So we have the synchrony in timing and in proportionality. This is the pilot work we did on the Servo 300 when we were starting with all this non-invasive NAVA. And this is a group of 7 low birth weight infants. And I just wanted to point out to you that compared to when they're intubated with NAVA and when they're extubated, so again, we're doing a single nasal prong, so it's non-invasive NAVA. You can see here that the trigger delays we observe when they're intubated did not get affected by that huge leak, and the cycling off delays as well. So the leaks do not affect the synchrony in terms of the control of the ventilator. Same thing, if we look at proportionality and whether or not this is affected by the leak, you can see here on the x-axis we've plotted the peak diaphragm electrical activity. This is the peak ventilator pressure, and the way that NAVA works is if you have a small EDI, you get a smaller pressure. A larger EDI gives a larger pressure, and you can see here that this proportionality was maintained when the babies were intubated. This is actually from one subject. And also when we ventilated with one single nasal prong, we were able to maintain that synchrony as well. So a little word about nasal prongs, and this is probably more for the neonatal group out there. All our studies were done using a 2.5 single nasal prong in one nostril, but we hypothesized that whether if we had 2 nasal prongs, that maybe the efficiency of the delivery of the assist would be improved, or if we increase the size of the prongs. And all we simply did was in the same animal model, we have the animal with lung injury, is breathing, it has a catheter down, and we're measuring the ventilator pressure delivered at the prong, and we're also measuring the ventilator, like the tracheal pressure. And all we're doing is plotting tracheal pressure versus ventilator delivered pressure. And you can see here that this is the line of identity. So clearly what we're delivering at the prong is not necessarily what's going into the trachea. And I think this is very important when you do non-invasive NAVA, because sometimes you can get those very high pressures at the nasal prong, but it may not necessarily be what's reaching the lung. And actually there was a study done in neonates in 2005, and this is with CPAP, but I'm sure it's the same thing with NIPPV, that when you look at a set level of assist in these babies, and you compare it to the pharyngeal pressure, you can see here whether the mouth is closed on purpose by a chin strap or if it's passively open, that there's a tremendous pressure loss. So let's say you're aiming to give 6 centimeters of water, you're only getting 4 in the pharynx. So what you're reading on the ventilator as that pressure is not necessarily what's going to the lung. I don't know what it is in a premature baby yet, but you should think about that. Another interface not available yet in North America is the helmet interface. I'm by no means an expert on this. Paolo and Antonio have done work on this, but it's a device that's very, it has nothing to do with leaks in this case, it has to do with compliance. And just wanted to show you work we did in healthy subjects, just looking at patient-ventilator interaction using pressure support with a pneumatic trigger. You can't see this very well, can you? And what we did was we also did pressure support with a neural trigger. So it's not NAVA, it's just pressure support. All we did was change the trigger mechanism. So here on the top tracings, you have your diaphragm electrical activity, and here on the bottom, you have the flow signal from the ventilator. And you can clearly see, as we saw all morning, severe asynchrony between the neural respiratory rate and the ventilator respiratory rate with the helmet. And then when we applied a neural trigger so that the EDI is now controlling the start and the stop of the ventilator breath, we start to see matching between neural and ventilator rates. This is a paper that just came out about the helmet that Paolo just published. Again, just to show you examples, this is a group of 10 patients, post-extubation hypoxemic patients. They were ventilated 10 or 20 minutes in pressure support and 10 or 20 minutes with NAVA with the helmet device. And so you can clearly see here the asynchrony between the diaphragm electrical activity and the airway pressure that was being delivered. And then when they put them on NAVA, that synchrony was restored, and we've seen a lot of these examples today. If you look at this asynchrony index, where above 10% is considered severe asynchrony, in the first pressure support and the second pressure support arms that they did, they had 7 or 8 out of 10 patients with an asynchrony index over 10, and none of the patients had this during NAVA. And also he looked at ineffective efforts, double triggering, and auto triggering, and these were observed during the pressure support periods, but absolutely no asynchrony during the NAVA periods. And just to lead in a little bit into Jean-Paul's discussion, I'm going to talk a little bit about how the upper airways play a role in lung recruitment, just to whet your appetite a little bit. This is taken from a thoracotomized and a lung-injured rabbit. This is CT scan images. This is when the animal is intubated on NAVA with no PEEP, and this is when the animal is intubated, is ventilated with non-invasive NAVA, and you have the upper airways that can now help with recruitment. And you can clearly see the difference between this figure and this one, and that there is actually the possibility of lung recruitment when the upper airways are liberated. So in conclusion, using a controller signal that is not affected by leaks can optimally synchronize the assist. Both leak and interface resistance will affect pressure delivery and may need an increase in the NAVA level. The EDI is useful for monitoring during non-invasive ventilation. And up next is how the upper airways play a role in this.
Non-invasive. So can you hear me? Okay, so I'm very happy to be here, and I would like first to thank the organizer for inviting me. I'm a clinician, a pediatric pulmonologist, but not at all an expert in the clinical use of NAVA. I'm going to speak as a researcher in respiratory physiology. So first, I would like to say that the interposition of the upper airways between the ventilator and the lungs represents a fundamental difference between non-invasive ventilation and endotracheal mechanical ventilation, especially with regards to the larynx, which primarily is a closing valve and whose original function is to defend the lower airways against potentially harmful intruders. In the 90s, the group of Rodenstein in Belgium performed some laryngoscopic observations in adult humans, and they showed that when you increase the nasal intermittent positive pressure ventilation levels, it was pressure support or volume control mode, they were able to see laryngeal closure against the ventilator insufflations. And in some patients, at least, they were able to show that this led to hypoventilation. And so what are the potential consequences? Of course, this can be beneficial because you might get pneumothorax if you increase a bit too much the level of intermittent positive pressure ventilation, but this could be deleterious, and they already saw alveolar hypoventilation, but this can lead also to oral leaks and leaks into the esophagus with the potential for gastric distension. We have been performing some follow-up studies in our lab during the last years in chronically instrumented newborn lambs, and increasing the nasal intermittent positive pressure ventilation levels, either pressure support or volume control mode, we showed that this leads to an increase in the laryngeal constrictor muscle EMG. So it's an active laryngeal closure against ventilator insufflations. So just remember that we are speaking of active glottal closure during inspiration, which is not at all normal for the larynx. This is an example of what we observed in a lamb. Yes, CPAP4. This is the EMG activity of the glottal dilator, integrated signal, glottal constrictor, the diaphragm, mask pressure, tracheal pressure, and the lung volume via the respiratrace. As you can see, in spontaneous ventilation and CPAP mode, you can see that with the inspiratory activity of the diaphragm, there is an inspiratory contraction, inspiratory activity, of the glottal dilator, but no activity in the glottal constrictor. Now, if you put this lamb on pressure support, and please note that the peak inspiratory pressure in this lamb was 10, so 10 with a PEEP of 4 centimeters of water. You can see now that there is a decrease in diaphragmatic activity and in the glottal dilator, but you can see that during inspiration, during the insufflations from the ventilator, there is a burst of phasic activity of the glottal constrictor, so opposing against the ventilator. And you can see also, if you look at the mask pressure, it's a square wave pressure support, but if you look at the tracheal pressure now, or the lung volume, you can see that there is some plateau right at the same time as the EMG activity of the glottal constrictor. So an increase in resistance, at least at the, probably at the laryngeal level. So what is now the interaction between the larynx and non-invasive NAVA? So our experimental design in lambs was as follows. On day 2 of life, we perform surgery for chronic instrumentation, and on day 5, we performed polysomnographic recordings with the radiotelemetry for transferring for the signals, and we will increase the levels of nasal intermittent positive pressure ventilation, and in a randomized order. So pressure support will use 10, 15, 20. This is peak inspiratory pressure, not the inspiratory aid. And we will try to reproduce this 10, 15, and 20 with NAVA. So the peak inspiratory pressure with our 3 levels is around the same values. And we will analyze the glottal muscle EMGs in this study in a quiet sleep. We have shown in prior studies that it's the same in quiet wakefulness. So this is again a spontaneous breathing, the same. So inspiratory activity of the diaphragm and inspiratory activity of the glottal dilator muscle, no activity in the constrictor. And if you look now in PSV, pressure support, for this lamb it was 20, the peak inspiratory pressure. You can see again the very nice burst of activity during inspiration, opposing the ventilator insufflations. And if you look now at NAVA, there is no activity of the laryngeal constrictor during inspiration or expiration. If we look at all the 8 lambs we studied, you can see here that on the left it's for pressure support, on the right is for NAVA. You can see that we got, finally we got inspiratory glottal constrictor muscle activity in 5 out of the 8 lambs, beginning with the 15 peak inspiratory pressure, and we never got any inspiratory activity of the laryngeal constrictor with NAVA. This is to show you again, this is the glottal constrictor during inspiration with the burst of activity during inspiration. In red, you have the tracheal pressure, and in blue, in red, you have the mask pressure, and in blue, you have the tracheal pressure. And as you can see, there is a difference between the two. If you look now at NAVA for about the same peak inspiratory pressure in red, you can see that the tracheal pressure wave follows the mask pressure wave. And so what can be the determinants now of inspiratory active glottal closure during nasal positive pressure support ventilation? In fact, we have shown in lambs that in lungs with upper airways isolated from the lower airways, and in other lungs with intrathoracic bivagotomies, we have shown that the reflex closure of the larynx originates from bronchopulmonary receptors, meaning that it does not originate from the upper airways. And a current hypothesis on the mechanisms triggering this reflex closure is that the shorter is the inspiratory rise time, the more frequently you will see this active closure of the larynx during inspiration. And we think also that the decrease in PCO2 may contribute, but we already have some results on that, and we can say that it's neither necessary nor sufficient to have a big decrease in PCO2 or to have hypocapnia to see this active glottal closure. So it's not dependent only on this hypocapnia. So to conclude, nasal intermittent positive pressure ventilation, and including pressure support, can trigger active glottal closure, which opposes ventilator insufflations. This could lead to decrease in lung ventilation, oral leaks, and gastric distension in some conditions. Contrary to pressure support, augmenting the levels of nasal NAVA never induces any inspiratory active laryngeal closure in newborn lambs, and this might be an additional advantage of NAVA over pressure support. And this is only to acknowledge the collaboration with Jennifer Beck and Norm Comtois, and also to acknowledge Amin, who is my PhD student and who is in this room. Thank you.
Thank you very much. That's very exciting data, very nice data indeed, and shows a good example of how potentially NAVA might be very useful for non-invasive ventilation.